Good afternoon and welcome. Thank you for joining us today for our training and introduction to creating a trauma-informed culture in the post-acute and long-term care facility, Part 4, Grounding as an Essential Strategy to Calm an Activated Nervous System, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence. We have a few housekeeping items before we get started. All lines are muted. Please use the chat box for questions and comments only. We ask that you complete the pretest survey if you have not. The link is in the chat. And now, I am happy to introduce our presenter for today, Ms. Paige Hector. Paige is a consultant, nationally recognized speaker, and author with over 25 years of experience in post-acute and long-term care settings. She specializes in diverse topics for the interdisciplinary team, person-centered trauma-informed care, nonviolent communication, sustainable process improvement, and advanced care planning. Paige writes extensively on topics relevant to nursing homes, including multiple chapters of Managing the Long-Term Care Facility, second edition, due for publication in 2023. She is actively involved in the AMDA Education Committee, the Diversity, Equity, and Inclusion Workgroup, and the Behavioral Health Advisory Council, as well as national work groups to improve trauma-informed care. In 2018, she was named Gerontologist of the Year for the Arizona Geriatric Society. It is my pleasure to turn it over to Paige to begin. Thank you, Paige.
Great. Hello, everyone. Thanks, Nikki and the Center of Excellence. It's always a pleasure to be here talking about topics that I absolutely love. So today we're going to continue. So this is part 4 of a 4-part series, and we're talking today about grounding, an essential strategy. And we're really going to focus on why this technique is so incredibly important and why it's something that we can do immediately, like literally starting today in your communities. So the objectives for today are talking about reactions, the things that people say and do as they're associated with an activated nervous system. What is the practice of grounding? And I'm going to, hopefully you'll be able to name more than 3 different options for you to try. Trauma-informed touch, and then we're going to talk about correlating trauma-informed principles and staff well-being. So in parts 1 to 3, here's just a list. I wanted to give you a flavor of what's already come before part 4, because each of these does tend to build on each other. So if you've not already listened to the recordings for parts 1, 2, and 3, I encourage you to do that, because I do think it's the foundation. It kind of contextualizes what we're doing in this part today. So here's the definition of person-centered trauma-informed care that I like to use. It recognizes the pervasive nature of trauma and integrates principles and practices to promote healing and recovery. And that's really what we're focusing on here today. I'm not going back over all the principles and the practices and nonviolent communication. What I'm focusing on today are the practices with grounding to help promote the healing and the recovery part. This is the stuff that we can start doing immediately. So before we jump into grounding strategies, I want to just center us for a moment on what the nervous system does when we become activated, language, emotionally stimulated, triggered. To me, all of those basically mean the same thing. So the nervous system is going to respond. So we see a stimulus in the environment. We see, hear, smell, touch. It could be the way a person looks at us, a particular day, a date, a time, anything at all can be a trigger. And then what happens is our nervous system gets activated. We get triggered. And what is happening is that tiny little part of your amygdala called the amygdala, which is the size literally of a shelled peanut. So it's super small. It goes on fire. It lights up the prefrontal, the cortex that shuts down. And that little part of your amygdala, that's where the memories are stored. And it's filtering everything to do a check, to basically make sure that your body is safe. It's asking 12 to 100 times literally per second, am I safe? Do I matter? Am I safe? Do I matter? Over and over and over again. And it's constantly comparing your current environment with all of the host of memories that have come before you in your life. And if there's anything that doesn't look very safe, it's going to trigger an alarm. We may say the person is triggered. So triggers are reminders of dangerous or frightening things that happened in the past. They could also be people. And I put an asterisk there because in the past could be yesterday, it could be 80 years ago. So there's no time frame on when I say in the past. It literally could be any point in time. And what's hard is that the current environment could be perfectly safe, but the amygdala has lit up and identified a potential risk. And it makes it difficult because sometimes the person may not even associate the current environment or something that triggered them with a past memory. So this is all very complicated work to a certain degree. And it can be hard for staff because at one moment we're having a conversation, doing an assessment, providing ADL care, whatever we do with our role. And all of a sudden this person is triggered and behaving in a way that's very puzzling. So as I put on there, absolutely anything can be a trigger. It can be a day, a season, holiday, anniversary, and it can be very puzzling for staff when this happens. So when the body is triggered, these are the messages that that brain is giving the body. I'm not safe. I cannot protect myself. I may actually die, or I don't matter. And then what happens is when the person interprets their current environment, even though it could be literally very safe, when that body says, something's going on, I'm not safe and I don't matter anymore, they may react in ways that other people, for example, staff, that may react in ways that people do not enjoy or do not understand. And that's when we say perhaps that a person is having behaviors. And I make it very clear that I'm very precise in my languaging. Languaging really, it impacts people. It impacts the way that we think and the way that we speak and behave. So what I really am asking people to do is consider this term behaviors and switch it to reactions. And the reason that we do that is because it's clearly identifying that the things that people do and say can actually be, in fact, reactions from prior trauma. So when they do things like I have here on this list, and of course, 30 years in healthcare, I've been around all of these as you are every single day. And it's very difficult sometimes to be present and provide care for someone when they're having one of these reactions. But here's the important learning part with this is that the link to trauma-informed care is understanding that those reactions could have actually started out as a coping mechanism, that in the time of the traumatic event, the distressing event, the frightening and scary event, that they did and said things that actually kept them safe at the time, even though they no longer suit the current environment. At the time, they made perfect sense. So I know for me, when I really began to integrate and understand that, it was a softening and understanding of why this person might be acting as they are. One of my favorite researchers, authors, world-renowned physician, psychiatrist, Dr. Bessel van der Kolk, in one of his books, he wrote that the traumas that we suffer throughout our lifetime, they actually imprint, and my idea was like a fingerprint, the mind, the brain, and the body, that they aren't just events that take place sometime in the past. It's an imprint left by the experience, and it has ongoing consequences for how the human organism manages to survive in the present. So remember, that the event happens, that somehow the person survives. So there's definitely some elements of resilience in there and strength. And that event can continue to impact them over a lifetime. It doesn't mean that we're defined by those events, but it does indicate that we can be impacted for the entire life by these events. The other important thing here is that the memories in the amygdala are not time-stamped. And why is this important? It's important to understand that the body will still interpret a current threat, even though it's not really a threat in the current environment, because it's associating it with something that happened in the past. So the body is reacting as though it's still fresh, because the amygdala doesn't timestamp and say, oh yes, that happened when I was 24 years old and that event is completely over. I have no reason to be frightened because I'm 85 and I'm not in that situation. That's not what happens. The memories are not timestamped. So here's two examples. An individual is attacked by a dog as a child, and now in your community, a pet therapy dog, and it's the most lovely, delightful, sweet, gentle, cuddly little critter. And this person has a reaction that's completely discordant with the current environment. It might be very puzzling for people. Now, this is a rather simple example. So this person is saying, "Ooh, no, 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 dog means danger, safety, I may die, I may get hurt." So for other people, the dog, like for me, it's going to indicate, oh, my amygdala has associated pets with a very good memory for me. So I'd be the person in your community saying, please, please bring the dog to me, but not for this individual. Another example, let's say a person was involved in an abusive relationship, very little choice in daily life. They were told what to do, when to do it, how much and how often. Now this person is living in your community and they're told, okay, so in this neighborhood or unit, our showers are in these days, or any semblance of being told what to do, that they perceive that taken in as that's the messaging. They could be catapulted back in time to when they were in that abusive relationship, even though no intention, of course, on behalf of the staff that there's anything threatening or abusive about any of this, but their memories indicate differently. So here's a visual of, I love this analogy here. This is the work of Sarah Payton in one of her books, is that the trauma memories are masses of associations that form vivid memories of emotionally significant seconds in a person's lifetime, and they become a glacier of events triggerable at any moment. So the glacier can move very quickly, and all of a sudden the person, like that ice chunk that's breaking off in this picture, they might be suddenly yelling and screaming at you, or sobbing uncontrollably, or they've got flooded with feelings of out of nowhere. The glacier can also move very slowly, and what that might show up at is when we say that they are declining or refusing care. Maybe they're even doing some things that we might perceive as self-sabotaging. So that could be an indication that there's some linking in that person's body, mind, that's linking something in their current environment with their past. So let me just do a little story with you to demonstrate the power of the amygdala. So let's say a person comes into your community following hip replacement surgery. Pretty standard, right? This is something we all do all the time. This is standard stuff. Here's the backstory. So listen. She was found in her home after being on the floor for 4 days, and the mail carrier sounded the alarm, as they often do. She was laying in a crumpled body position, a puddle of urine and feces with very strong odors. The phone is just out of her reach and ringing intermittently until it dies. There's a pet whimpering with fear and hunger. The pressure of the walker is stuck beneath her body, and the feel of the cold tile is on her face, and the horror that she could die and die alone, with other intense emotions like shock and pain, terror, and confusion. So what we see is the resident coming in. She has a diagnosis of a hip replacement. She has a few other medical things going on. Discharge plan is to return home. Okay, we do that all the time. The backstory here. So what has happened with this human being is that her amygdala stored all of that sensory input. And remember, her amygdala, like yours and like mine and your children and your partners and spouses, our amygdalas are constantly scanning for threats to our safety. So her amygdala is doing that. She may not even be, we often are not aware of what's happening, that her body could actually react. So let's say, for example, you go in to do a PT consult or anything at all, provide care or just speak with her, and something happens that triggers her, that takes her back into those 4 days when she was on the floor, terrified that she may never, that she may not survive. So this is how that part of our brain helps to keep us safe, even if the current environment is safe, but she's still reacting as though she's not. So there's a few things that happen when the nervous system indicates there's a threat. So what I envision is that the more that we can teach and support our staff to understand these, I think of as clues, the physiological clues and changes that can say, oh, there might be something going on here, that this person could actually be triggered. So if we can help staff to understand that when a person is triggered, even if it's something that we as staff do or say that is the stimulus for that person being triggered, it doesn't mean that there's any sense of blame. That, it's not a matter of staff doing right or wrong. It's a matter of picking up on the clues in the environment to help say, oh, when I said this, or I did this, or the environment was perceived as such, Mrs. or Mr. acted like this. Oh, I'm going to link these up. There's possibly some triggering that's going on there. So pupils that dilate, muscles that get tense. You can tell When a person's triggered by their changes in posture, perhaps they're hunched over. Hunching over indicates more of a shame response. Perhaps their body has gotten very large, as though they're in a mobilized fight response. Repetitive movements like twisting their fingers, twisting a tissue, bouncing their knees. Maybe you see some tremulous hands. Maybe they'd start chattering. There are changes in speech and breathing. So all of these can be clues that something is going on with this person's mind, brain, and body. So here, I love lists. I really love visuals. I think, how can we use this to help support our staff? So imagine having this as a printout in your community. These are all the ways, and there could be many more in here, and feel free to change this list up in a way that works for you. But these are all the different ways that our body does things to give us those clues, all those sensations that can show up that indicate that we're relaxed, that we're comfortable, or perhaps that we're agitated and in high discomfort. So the more that we give language to all of this stuff, the better that we are going to be able to integrate trauma-informed care principles and to help create those healing environments to help people deal with the impacts of the traumatic events in their life. Here's another idea. So this is, again, the work. I try to give credit wherever it comes in. So this is Sarah Payton's work. This was wonderful. This is called the anger continuum, and it's a way that we can look at the words that we use as we perceive that we don't matter as much. Perhaps we get triggered by something or something's happening. And as we grow in intensity, so you'll notice here, do you see how it starts off with words that, and again, you can mix and match these words, do what works for you. Kind of a sense of dissatisfaction. I'm a little irritated or a little bit pissed off. And notice how we go down and then the line would go up here. So this would be, in my mind, all one list, down to words like seething, incensed, enraged, and livid. So the more that we can give movement and fluidity to these emotions that are happening in our body, the more that we can give language to them. Imagine being able to use this kind of a visual with staff, with residents, to help name what their bodies are doing, because the more that we can name, the more effective the grounding practices that I'll get into in just a minute are going to be. Here's another strategy. Strategy just means intervention or idea. So this is the hand-brain model by Dr. Dan Siegel, psychiatrist. So if you were to put your thumb, and I'm going to try to demonstrate here, put your thumb, tuck it in, and then put your fingers over it so it looks like the picture. This part here is now called your prefrontal cortex. This is your brainstem here. So what happens when I'm calm and I'm grounded? My brain would look like this. My prefrontal cortex, the part that has the ability to regulate my emotions, my fear modulation, the ability for me to engage in conversation, to have empathy and problem solve. My prefrontal cortex, yep, I'm online, I'm engaged, I'm good. Now, let's say I get triggered and something happens in the environment. What happens is, boop, the prefrontal cortex literally goes offline. It flips the lid. So now my little amygdala here is the one that's running the show. Memories are not time-stamped. It's constantly scanning. It's identified a threat. My prefrontal cortex goes offline. So imagine, I know that they're across the country, that there's schools and school systems that actually teach this model. I'm thinking, let's teach it to everybody. Every adult should know it. This could be language that's nonverbal. If I had a staff member that said to me, my lid is flipped, I'm thinking, oh, gotcha, okay. And then I'm going to have some strategies for you. Well, what can we do with staff in the event that their lids are flipped? So again, it's language. It's how do we bring this material to life? Here's another idea. So what's your temperature? This is a feelings thermometer. And you can see here, I'm giving not only language, but visual. You guys, we're familiar with like the pain scale, 1 to 10, 10 being the worst pain you've ever experienced. It's the same thing here. So in the green zone, the blue zone, you know, I'm okay, I'm calm, I'm collected, I'm getting a little more yellow, I'm a little uncomfortable, but I'm still okay, I'm still present. But now I'm heating up and I'm going to explode on you. Okay, so again, it's giving language. It's giving language. Here's another idea. This is from the Stress First Aid Toolkit, which is a fabulous, they actually modified it for long-term care, by the way, and there's a lot of trauma content. So here's over here, again, a visual. Imagine having these posted in places that give your staff language to use. So over here today in the green zone, I'm good, I'm able to help, I'm able to contribute and support my colleagues who are maybe getting triggered today or arriving at work having had a difficult morning with the partner, a family member, a child, or a situation, I'm available to support. Over here, yellow. Oh, I'm orange today. I'm struggling. Oh, I'm in the red zone. I'm the one needing support today. And I'm naming specifically how lovely this is to be able to say to our colleagues, to say, I'm here, I'm going to do my job, but I also need some more support today. Maybe tomorrow I'll be more present to give it to someone else. The idea here, radical acceptance, I love this concept. It's accepting our reality without resistance. It doesn't mean that we deny it. It doesn't mean we try to ignore it. It says, okay, this is happening right now. I am not loving it. I accept what it is. And then I'm going to have strategies that I can do to help make it better for me, to help me feel more grounded. So it's, okay, this is what's happening. How can I manage it? What can I do? When our brains are on fire, whether it's trauma, anxiety, distress, fear, any of those really strong emotions, it's very difficult to remember strategies like grounding strategies. So that's where, to me, this is such wonderful work that we can begin immediately to integrate and help teach our staff to then help support residents. But guess what? It works for us too. All of us can have our own grounding strategies. So what are they? So grounding is a method of distraction when a person's experiencing stress or distress in the form of specifically disturbing thoughts, memories, feelings that connect the person and connecting the person with the present moment. So they've been triggered, emotionally stimulated. And these strategies, like this amazing image I just love, it's literally ground being present and back in connection with your body, first of all, but your body in relation to earth. Okay, so it's connection. The idea of grounding strategies helps shift us from, I love this idea, the then and there, because remember, the memories aren't timestamped. So it's what happened before in my life, and it's shifting me to the here and now, to the present moment, then and there to here and now. So that's what grounding strategies do. So the strategies, I'm going to give you a lot of them to think about, to play with, to practice. They really attend to specifically principles of trust, safety, choice, voice, empowerment, and collaboration. So it really, it touches on many of the trauma-informed care principles. Generally speaking, our nursing homes are pretty functional environments. We have all of these tasks to do, ADLs, and providing care for people's bodies, administering medication, all of this stuff. The grounding practices, to me, just bring back that relational, interconnected aspect that I actually believe that all of us love very much, but I fear that we're getting more and more away from it because of how many tasks that staff are being given each and every single day to incorporate into their workflow. So to me, this is really getting back to what really matters to us as staff. So big grounding. I think, to me, one of the most important grounding strategies is breathing, is breath work. The deep breaths that really engage your abdominal muscles, that tummy area, that core area, instead of those short breaths that almost indicate that we're not breathing deeply, we're almost hyperventilating. This was interesting to me years ago when I first started studying this content. This came out of the Compassion Fatigue workbook, that the exhale is actually super important, that we want to exhale the carbon dioxide. Yes, we want to exhale all of that in order to be inhale the fresh oxygen. So typically we say, take a deep breath. Actually, it should say exhale a deep breath. So we exhale through the nose and inhale through the mouth. There's tons of different breathing techniques. I put a few here. This is the box breathing, where you exhale, you hold for 4, you inhale, and you hold for 4, and you do as many rounds of this as necessary. And I'll give you some information about, well, how long and what would we notice once we engage these activities. I'll talk about that soon, but this is but one strategy. And then I did a little research and I thought, okay, I'm comfortable sharing these 3 websites. I thought these are websites that might be supportive to you. So my idea is that you can create a toolkit of sorts of all these ideas. Maybe I have visions of binders of all of maybe these slides that have all of these ideas as you begin to integrate and incorporate these ideas into your daily workflow with one another, your own selves, and with your residents. Another good one here is opening and closing your jaw really wide to elicit a yawn. I don't know, I love images. I'm a visual learner, I'm a visual teacher. So to me, these just make my heart feel happy. You can have a baby yawn. I can be talking to somebody on the phone, and if they yawn, I'm going to yawn. And what that does is it really invites that breath to come in. We don't really know why it does that, but it does. Movement is critically important. Typically, when a person is agitated, triggered, and in a state of emotional reactivity, they get very constricted. So what we want to do here is move the body, literally wiggle your butt, cheek to cheek to cheek, feel your butt on the chair, move your feet, stamp your feet up and down, literally reconnect your body with the ground, with the earth. Movement, wiggle and twirl your toes. So even if you can pop your shoes off, fabulous. Squinch up your toes really tight, curl, 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 and then release, and curl and release. And it's really literally, it's reminding your brain and your mind, I've got a body and I'm going to get my body grounded. Rub your hands briskly together. I can feel the warmth. I can hear the sound of it. I feel the friction. Stretch your hands way up. So anything that gets my body moving is a wonderful grounding strategy when someone's activated. Others, what do you see? What do you look at this? It could be anything. What are the colors you see? What are the objects? Another way to do this particular strategy is name the biggest object you see down to the smallest, or vice versa. Name everything that's blue, name everything that's brown. There's many different variations. What do you hear? It's amazing when you are really quiet and still and you are focusing your attention on hearing. What you can hear is the air conditioning humming. You can hear someone speaking way down the hall. Maybe you hear something that you never paid attention to before. Going outside, like I've said, grounding, going outside if possible, and doing these same things outside, biggest to smallest, everything you see, what are the colors you see? The more that we can incorporate touch with grounding, that's really great as well. There's actually a book on it. It's called Forest Bathing. Dr. Lee is a world-renowned forest bathing research medicine expert. It's the art and science of how trees can promote physical and mental health. Literally, it's an area of research. If you can get people outside, please do that. Have them touch and feel and experience the environment. This came out not too long ago in JAMDA, Journal of American Medical Doctors Association. It really caught my eye, and here's why. It says that there's a lower incidence of in-hospital falls in patients near the window. Why do you think that is? I mean, what they postulated in this research study is that perhaps it could be due to exposure to natural light. Absolutely. I'm also wondering if it's because they felt more grounded, because I gotta have windows. If I don't have windows in my work and living space, I get very agitated. So I would be curious, if you were to go back and look at all of your falls and room falls, how many of them were bed and how many of them were door, bed and door? Or window and door is what I meant to say. Here's another really good one, holding an ice cube in your hand and letting it melt. Now, if you are working with someone who's so agitated that you're worried they could throw something at you, don't give them an ice cube. This is a really great strategy, holding the ice cube, but not just holding it, noticing what it's doing in the pool of water it's making, how it's feeling, the cold sensation. So you're really trying to embody the actual experience of watching the ice melt. Naming categories. This is great too. You can name any kind of categories, colors, objects, fruits, vegetables, animals, cars, trucks, cities, cars. It doesn't matter. Pick a category. Whatever the category is that's meaningful to the person, and begin having them name them. Make it playful. Make it a game. Music, and we're nursing home people, so we know the power of music in memory, and all the research with that. The more that we can incorporate our favorite songs, this is a great grounding strategy. Music can give you chill bumps. It can give you goosebumps and chills. So what happens when we listen to music over and over? Guess what our body's doing? There's a neurotransmitter, dopamine. It's going to give us a flush of dopamine. That's a really good feeling. We want more dopamine flushes. So why do we play our favorite songs over and over? Because we're getting dopamine flushes. Taste is also another good strategy. Strong flavors, a mint, spritzing lemon or lime, or even I love those smells anyway. Those strong flavors. Now I want a little bit of caution here. I don't want to see a bunch of care plans. Oh, we're just going to give them snacks every time. I did see that one time, and guess what the unintended result was? Of course, it was weight gain. So that was not a good strategy. Smells like peppermint, for example, bathing salts, oils. Obviously, we can't use candles in nursing homes, but that kind of thing is creating that environment. So when we put aromatherapy in a care plan, be precise. What smells are really meaningful to this person? How do we make them available to staff? How do we use them and incorporate them? Texture and touch, really, really powerful again. So for those of you who have kiddos, or maybe you had kiddos and they're out of school now, they probably did one of those exercises where they have to go gather a bunch of things and put them on a piece of poster board, different textures. This is a really good exercise, actually. So again, we're taking the person out of the body experience, out of the stimulated, whatever stimulated experience, and trying to ground them in their bodies. So the more that we can incorporate textures, it's great. This little girl here, this was a wonderful, she's hugging. So there's multiple things going on, sensory stimulus for her. She's hugging, she's got the pressure of the teddy, she's got the sensation. I'm imagining there's a smell with the teddy as well that's very comforting. Guess what? It works for adults as well. This is a darling story. This is in England. This is, at the time, 94-year-old. And his wife had died, and he had gone to bed every night in his assisted living or nursing home community with a picture frame of his wife. And the CNA created this pillow. You can see the wife's image here, and it just touches me. Look at, he's showing, look at her. Isn't she beautiful? This is my bride. This is my wife, my best friend. And the pillow, so it was a lovely way to incorporate many things with that. So really good grounding strategy. Laughter and tears, absolutely. This is super duper. What makes people laugh and what makes people cry? Even if it's tears of sadness, joy, tears are very cathartic. I'm a sucker for this video. It's Susan Boyle, 2009. She came on the stage of Britain's Got Talent, and she sang I Dreamed a Dream. Every time I watch it, I laugh and cry at the same time. Siri commercial, it's ridiculous, it's Cookie Monster, but it's so dang funny. I laugh every time. So sometimes I just pop it on because I want something totally, it's not related to work, anything else, and I just want to laugh. Laughter whenever you can. This is a picture of in a nursing home here in Tucson, and she just dressed up. Even during the height of the pandemic, she did everything she could to make people laugh and to bring joy. There's actually a super cool TED Talk that I encourage you to listen to. Play it for residents, play it for staff, really bring laughter. Pets, of course. So we know pet therapy is huge, snuggling animals, thinking about someone who loves us. Now, this can be someone that's currently alive or someone who has died. It doesn't have to be a person who's living. So the really cool thing about the amygdala is that it also makes positive connections, right? So it's not just the scary, terrifying, negative things that happen in our life. It's also those warm, yummy memories that we have of a special person or a connection. So the more that I can stimulate and bring those experiences online when the individual is stimulated, that's what we're doing here. Another one, rerunning favorite sporting events or movie scenes. This is super cool. Like if a person has a favorite touchdown scene or whatever scene, a movie that they can shift, literally consciously shift their attention out of what stimulated them into thinking about that. I like this scene in ET. It's those types of things. So these are the things that we then put in the care plan. Picturing a beautiful place in nature. This is a sunrise where I live in Tucson, Arizona. So it's picturing things. It's what would it be like if I was a resident in your community? Please print this picture for me. Put it in my room. Make it visual for me. Make it accessible. Compassionate self-talk is another really good one. There's so many different things you can do. So this is Imam Jamal Rahman. I did a training with him years ago, and it was just wonderful. He would really say, friends, he would say, put your hand on your heart. Put your hand on your heart as you recite a mantra like, oh, Paige, your soul is aching for peace and comfort. I hear you. I hear you. And you do it over and over until you feel that sense of calm. I tell people, give yourself grace. We are working in some of the most difficult, challenging times, pandemic notwithstanding, but that certainly did not make things any easier. So these are extraordinary circumstances. How can we give ourselves grace? Using mantras, again, it's one thing to plop a mantra in a care plan, but how do we make them come alive for people? Where can we put them? Where can we post them? Can we laminate them? Put them in a booklet? It's not enough to just put them in a care plan. So how can we make these things come alive? I put some mantras on. These are actually some that I used one this morning on my walk. So they have to be intentional. A calm, safe place. This is really this is from EMDR, so eye movement desensitization movement, which I'm not teaching, but this is an element in a strategy that's very good in EMDR work that we can use with not EMDR. So it's a resource to help us focus, ground, get balanced when we're feeling any of those overwhelmed sensations. So how do you identify your calm, safe place? Here's the prompt. Where did you or do you go to have fun or to relax? I realized for many, many years, even through when I was in college many years ago, I would have an image of a pier, just very quiet pier. And I live in the desert, so why that was always my image, I don't know. But that was my calm, safe place. And I didn't even realize I was doing that. So what's your strongest memory of this place? Imagining sounds and emotions and these smells that accompany it, make it a full-bodied experience. This is what you do. And then you associate a cue word with it, a keyword that cues you into going to that safe place. So it's a trigger word in a good way. So then you create, this is a fabulous thing from the sanctuary model. It's a personal safety plan, grounding strategies in action, right? We got to do these. They've got to be intentional. So you look at 3 to 4 things that help you ground, and there's all the prompts here, and I'm doing a lot of material in a short time. I'm going to trust that you'll take these slides and look at them. So what you want to do is you want to also remember that it's important to practice grounding strategies when we're not feeling stressed, because it's the same thing like if I want to lift weights and get stronger physically, it's the same thing when I'm training my mind to do something different. So you could actually put, this is, I created this little guy here, this little thing on the side. These are my mantra, the things that I do. But then you can also do this. This is a colleague of mine, a social work professional that does mental health trauma work. And she actually puts these things, this is the back of her ID badge, okay? So she does 3-2-1 grounding, 4-7-8 breathing, and the dancing giraffe. This is her little daughter who made this giraffe picture for her. So when my colleague looks at this, oh, it just settles her. She's got the loveliness of her little girl and this picture that she made for mom. So these are the things we're talking about. So there's intentionality that we're literally, I'm changing the track from over here, stimulated, agitated, horrified, and I'm going to purposefully change tracks. That's what we're doing. The experience of settling. I even used to take a jar with me when I would do trainings, and I would take a jar, a glass jar. I went out and put mud in it, and I would shake it up. And that's where we are when we're agitated. We're over here, and it takes a bit of time to let the experience settle. The experience won't go away, but we're getting grounded in the moment. And then what happens when we're grounded in the moment is that we have a sense of relief. Several slides ago, when I talked about what happens physiologically when we get stimulated, our pupils dilate, we get constricted, we change our breathing and our speech habits, our patterns. When we get grounded, all of those things kind of undo. The person might exhale. The softening of the face, the dropping of the shoulders, there may be tears. Tears are so cathartic. They're very good. Goosebumps, a pause. You can actually feel the energy shift around them. So these are things that I would love to invite all of you to be practicing for yourselves, for people at work, our residents, but also our children. The more that we can bring these skills on board, to me, that's bringing more trauma-informed care into our world. So again, here's the slide that we need to practice these things when we're not stimulated. So our brain gets more fluid and adept at bringing these things on board when we begin to we notice the sensations that we're getting triggered. It's not a one and done. I want to segue into 2 remaining topics here. So that's a ton of content, but here I want to talk briefly. There can be a very good grounding strategy of touching, but I want to bring a little caution. So do we touch? Do we not touch? Well, and I'm going to say, I don't know. It's going to depend on a lot of things. Here's what we do know. Sexual assault, according to the CDC, is sufficiently common that every long-term care facility is likely to have multiple female and male, please remember, and male residents who have experienced rape, attempted rape, or contact sexual violence. we need to keep this in mind, that whenever we go into touch or provide care to someone, do not assume that they welcome our touch. Here's some considerations. If I have a resident, and I'm a very touchy person, I'm very much, I love hugs, I love to hold hands. When I was in the nursing home, one of the ones where I worked, I was very much the social worker that would be very loving with residents, and you've got to make sure that they're welcoming that. So if they approach you and they're wanting to hold your hand or to reaching you for a hug, pretty sure that's going to be fine. So just be aware of that. So as we train staff and bring these principles on board, make sure we're putting this in context that are typically, well, always, staff are going to be in a power over position. So what we do with trauma-informed care principles is we want to level that power. We don't want to power over people. We want to have power with people. That's a key trauma-informed principle. So being very careful to understand here that staff are more than likely in a power over position. So what about residents in a coma? Don't know. It's uncharted. So in my practice, when I would go in to see a resident in a comatose state, on a ventilator or not, I would always talk. I would always introduce and tell them what I'm doing and my next steps. If there's touch, perhaps more transient touch, we just don't know. But maybe you can get information from the family if they're available. What was this person like? Did they welcome that kind of touch or not? So just be very cautious with this part. So don't assume everyone wants physical touch. So read the situation. If it appears that touch would be welcome, ask them, would you enjoy a hug? Would that be something you would like? This picture just makes me happy every time I get to look at it. If there's a nonverbal invitation, or if there's an opening, like I said, that they're reaching towards you, there's a good indication that if you're comfortable with it. I want to keep in mind too, that our staff also have histories of trauma. So that's a principle of trauma-informed care, the universal precautions that we all have trauma histories, every single one of us. So we want to make sure that we are giving that permission and that empowerment, the voice and the choice, trauma-informed principle, to staff as well, that just because a resident is reaching for them for a hug does not necessitate the staff to respond in kind. But we need to be able to support staff to figure out what they're comfortable with and then how to react in those situations, what they are comfortable in doing and not doing. Okay. So again, we've got all these strategies. What do we do with all of this stuff? So I briefly mentioned in the beginning, if we can take all of this content somehow and create some kind of a toolkit, a resource, a binder. So as we work with people and we integrate and we begin to put these strategies into practice, how can we make these accessible? So as you're doing your whatever your workflow is, your stand up, your stand down, your IDT meetings, your care conferences, whatever it is, how can we use these to integrate person-centered, trauma-informed care? So that's really where I come down to all of this. We've got this F tag. We all know what the F tag is. How can we do this work now? So I don't want to read all of this. I read the regulations actually quite frequently because I like to refresh my memory what they are. And these are some points here that, to me, the more that we incorporate grounding and giving people, helping put them back in charge of their environment and their body and how they want to be touched or not touched, or what works for them or doesn't work for them, that's what we're doing here. So on this slide, I just started brainstorming. Okay, what are some prompts that we can maybe ask ourselves to determine, are the care plans in your community just exercises in regulatory compliance, or do they really uphold PCTI principles? If I look at the care plans, do they really tell me that this is the way I love to teach about care plans? I should be able to look at a care plan in a community and know exactly whose it is, because it's sufficiently individualized enough to say, yep, she really likes this. This is what her triggers are. This is what we do when this happens. And this is our next move. So it's a blueprint, if you will, to help support staff to provide PCTI care. So does it emphasize the resident's strengths and resilience? Does it identify the human being and not just a set of disabilities or problems? I know I've read just thousands of care plans in the typical format, and I want to acknowledge the EMRs don't give us a lot of support here. They typically focus on all the things that are going wrong. What we're talking about here is focusing on strengths-based resilience and bringing in the things that are going well for people, and then trying to do more of that. So here's just a few prompts that I thought would be helpful. Does the care plan include known and potential triggers for reactions? Remember, we're not going back and saying, oh, these are all the events that happened in this human being's life. What I want to know are the impacts of how those events are showing up today in the present environment in my nursing home or my assisted living. Is it clear what staff should be doing? Not just what they shouldn't be doing. I noticed this is a tendency a lot, and this is our socialization. We tend to tell people what not to do. What I want us to do is focus on what is it we're hoping that they will do. Okay, that's the shift that we're talking about here. So, and then are all staff on all shifts informed of the strategies? I'm always very cognizant to make sure that our evening and night staff and weekend staff are just as much in the know as our daytime Monday through Friday staff. So we need to make sure that they're given as much training, coaching, and mentorship and resources as the daytime staff. The other thing I want to ask us to do, this is a request from me, if we could move away from everything we say, oh, that's a behavior, shifting away from behavior plans, I would love to see them called connection plans. Okay, we've got a few moments left, and I'm going to just take a peek. I've noticed really quickly here in the chat box. Let me just take a peek and see if I can address these real quickly. Kathleen, the slides will be available. The COE will provide them. Thank you, Samaria. Helpful to me. I do not like touch, and when residents grab and hug me who may be cognitively impaired, I feel obligated to return the hug or touch. I kindly and obviously redirect it, but it makes me feel badly inside. Yes, I feel so much better now that it's knowing it. I have full body goosebumps reading your reaction to what I just taught. There is nothing bad or wrong here. What I want to say, that's a beautiful example of you advocating for your own needs. Our staff have needs just like our residents do, and some of us do not like to be touched. Please, all of the power on this call right now, normalize that. We do not expect our staff to be subjected to situations that cause discomfort or that might trigger them. Thank you for sharing that. So Janice, as for me, I'm a hugger toucher. So I guess yes. So now I love that I'm hearing, I believe that you have more context of how and when to approach that, the touch that you're very comfortable with. And I hear that you want to make certain that the person that's on the receiving end is also comfortable as well. I'm a hugger too. I've learned that who I can hug and who I shouldn't. Absolutely, Ivy. We don't want to create or be a stimulus for discomfort for anyone. Thanks, Nikki. Saw the slides. I like the word connection better than behavior. I do too. I love it. Thank you. So with our MDS documents still referring to, yes, behaviors and the requirement to have care plans, how do you suggest we make the transition to reactions and connections? Yeah, I do have a magic wand. I'll show it to you. It's not really magical though, but I pretend. I want to wave it and just make all of this easier for all of us. What I don't have is an answer. What I do have is the conviction in my soul that the more that we talk about this, even if I have to dance the dance of the CMS and the MDS and the EMRs that don't support the work that we know is so important, I believe that the more that we talk about these things and say, we are not doing behavior care plans anymore, we're doing connection care plans, write a policy, write a statement for your community, involve your residents, involve your patients and families, get people on board. I believe that these little acts can actually snowball and create something magnificent for all of us. That's my take on it. I hope that's helpful. Let me shift. I have about 4 minutes and I want to talk about you all, staff, even more. Thanks, Katie. Exceptional presentation. Thanks. That makes my heart happy. I love what I do. Staff, let's talk about you. And I've said it again and again and again, and I'll say it again. We all have triggers. We are human beings that have triggers. And just like that glacier, that iceberg, we too have our own icebergs. And we don't just leave the iceberg at the door when we walk into our nursing home or assisted living. It comes with us. So staff, I've taught this presentation so many times in the past week. I keep telling people, create these environments for our staff first, please. So what is the awareness that we can bring to our staff? What is the awareness that we can bring, and how can we incorporate these grounding strategies to normalize when our staff, when we have triggers to our environment, when residents do and say things that trigger us? It goes both ways. No blame, no shame. It just simply is. So how can we grow our capacities around that? One of the ways that we can do that, and again, I could create a whole session just on impact sharing, but I want to introduce you to a concept, impact sharing. Impact sharing supports multiple trauma-informed care principles: safety, trust, transparency, peer support. It actually covers almost all of them. So what it is, here's the deal. When a person is in an environment and something has happened, either someone has done or said, and it impacts that person, impact sharing is being able to go to a supervisor or someone else that has the skill set and the communication skills, which are founded in empathy, to be able to share, this thing happened. I am feeling this because my needs for safety, for security, for belonging, for connection, all of these things are not met. I need support. That's what impact sharing is. So the more that we create this environment for our staff and create this safe environment for staff, I completely believe that we will be able to do more of it for our residents and patients. So what are they feeling and what needs were not met? What experiences? And I'm not saying, oh, go and dig deep for their trauma memories. No, we don't do that. What I'm saying is you give permission for that staff member to say, this is impacting me today, and I'm not even sure why, or I know why, and I'm not going to tell you, but I still need to talk about it. I need a break. I need a break from the unit. I need to be reassigned. I can no longer be effective and provide care to this person. It doesn't mean that the staff is right, the resident's wrong, none of that business. It simply means that we are human beings with capacity limitations. The other thing is that impact sharing comes before education, discussion of policies, advising, reassuring, or problem solving. Put that on hold, folks. Until a person is seen and heard for what they're feeling and needing, please don't just start, well, our policy is, or I think you should, or why not this? Don't do any of that until they completely have the sense of being grounded in their own body again, and then you go to that next step. Last word I'm going to say, and then I'm turning it back over to Nikki. What is capacity? We have limitations, every single one of us. But not only do I have limitations of how much I can show up and what I can bring to my work, there's also institutional capacity limitations. There is only so much that each individual can do at a moment, but collectively as a team, there's just so much we can do. And it doesn't mean that we're bad or wrong, or that we're not capable, or we're not loving enough human beings. It's none of that. It's simply saying that we have limitations. There's some information here, a couple of my favorite articles on this stuff. For those of you who enjoy reading, I provide all that to you. We are wrapping it up a smidge early today. So one little thing you're taking with you, if you want to pop it in the chat box while Nikki does her closing comment.